Firstly, many people with mental disorders in the community don't receive treatment. People have called this the treatment gap. And getting more of them into treatment should improve population mental health. However, despite large increases in the provision of treatment in high-income countries, including Australia and New Zealand, there's been no measurable improvement in the mental health of the population. And possible explanations of this include a lack of quality of treatment, something I've called the quality gap, and also a lack of action on prevention, something I've called the prevention gap. Okay, now you can have lapses of attention and it's okay. So let me begin by telling you how I got interested in this topic. So when I was much younger than I am now, I was in my 30s, in the 1980s, I worked at the Australian National University in Canberra in a place called the Social Psychiatry Research Unit. And we worked in this house there, which overlooks Lake Burley Griffin. It's one of the earliest houses in Canberra. And this is the director, then director, Scott Henderson. And this is me at the back, and you could see I had a little bit more hair then, not very much, but a little bit more hair on the top of my head. Anyway, when I was there, I read a book called The Role of Medicine by Thomas McEwen. Has anybody ever read this book? You have? Wow, you don't have many people that read it. It's worth reading, really worth reading. It's a classic book in public health. You can read it in a few hours. It's an old book now. But what it consists of basically is a series of graphs, and I'll show you one of the graphs. It's a book about the history of infectious diseases in England and Wales over some centuries. And in the book, Thomas McEwen just gives graph after graph of various infectious diseases and looks at mortality from those diseases. So this is the graph showing annual TB deaths per million population from 1840 up to 1970. And you can see here, he puts little arrows on here where we understand disease mechanisms and where we get various effective interventions. And in most of the graphs, things were getting better and better and better. And McEwen is not saying that these things didn't work. He's just saying a lot was happening in society as well. A lot of things were going on there, and in many cases, what got the credit, which were these interventions at the end, were like winning the last battle of the war, as it were. So having read that book, it really made me think. And I realised that up until that time, I thought, well, the best evidence is randomised controlled trials. That's how we know whether interventions work. And it is good evidence. But it also pointed out to me the value of looking at population monitoring and the history of diseases in population to see the effects of interventions. And this was a nice complement to what was happening in randomised controlled trials. And I thought, we need to do this in mental health, in my area. So during the 1980s, I went and looked around to see, is there anywhere in the world where you could get data, where you could look at the impact of interventions on population mental health. And I found the data simply didn't exist. We had data on the suicide rate, but that's very imperfect, and that's it. So I thought, okay, we need to start monitoring in populations across time the uptake of various interventions and the impact on population mental health. So that's how it all started. So I had this in the back of my mind for decades, really. And in the 1990s, things moved on a bit and we got a little bit closer to maybe being able to do it. And two important things occurred. I'll tell you a little bit about both of these in detail. I'll tell you what they are, first of all. The first one is we started getting national mental health surveys. And these showed that mental disorders are very common and they're often untreated. And the second thing we got was the Global Burden of Disease study, which showed that mental disorders are a major cause of disability. So usually at this point in my talk, I show you Australian data on the prevalence of disease. Well, I'm not going to do that. I looked up the New Zealand Mental Health Survey. So Australia got its first national survey in the 1990s. New Zealand was a little bit later, 2003 to 2004. It's got its national survey. It was a really good survey. It was one of a whole lot of surveys that were going on throughout the world in different countries. And in that survey, they gave these data on the 12-month prevalence. That is, what happened is lay interviewers go into people's houses, they interview them, put the data in a computer, and an algorithm churns out a likely diagnosis. They ask people whether they're getting services. So if you ask people about symptoms they have in the previous 12 months, you can get 12 months prevalence from that. And for the Maori population, it was 30%, for Pacific people, 24%, and for the rest of the population, it was 19%. In Australia, we got 1 in 5 people a year was the figure of adults. When you look at the people who are untreated, what's being called the treatment gap, for Maori it was 68%, Pacific people 75%, and for others 59%. So it's substantial. Most people who are diagnosed in these household surveys were not getting treatment. Now, that was shown again and again across the world. So in all countries surveyed, that treatment gap exceeded 50%, and in the least resourced countries, it exceeded 90%. Now, okay, so that's the first thing that occurred in the 1990s. The second thing that was important was the global burden of disease study. So the reason this was important is that when we evaluated what are the big health problems in a society, what we looked at historically was what killed people. Okay, so when people die, doctor writes a cause of death, they've been compiled. In Australia, it's well over 100 years. I imagine New Zealand, it's equally that. You can go way back and you can look at the history of mortality from different diseases. The big problem with that as an indicator of population health, it only looks at what kills people. And we know that a lot of things can impair their life, cause disability, but don't kill people. So people could suffer from arthritis, for example. May not shorten their life, but it can make a lot of suffering. And when you get to mental disorders, they are in that category. People do die by suicide, they die by anorexia, but primarily they're not killers. They're primarily disablers. That is, they make it difficult for people to fulfill their life goals. It's difficult for a young person to study. It's difficult for them to work. It affects people's relationships and so on. So this is what they meant by disability. So in this global burden of disease study, they came up with this technical thing called a disability adjusted life year, or DALY. And I'm not going to explain it to you. I could, but I'm not going to explain it to you, but you can understand it intuitively. What it was a very clever way of combining together the impact of diseases that shorten people's lives and diseases that impacted people's lives so that they couldn't fulfill their life goals. And when you did that, mental disorders came up as really important. So people thought about them as much more important for population health than they had before. In fact, they are in high-income countries, they're the major source of disability. And in particular, depression came out as the single big cause of disability in the population. And that got enormous attention to depression as a public health issue, that it wasn't there before. Now, normally at this point in my slide, I show you the Australian data on burden of disease, but I looked up the New Zealand data. So this is what I got from health loss from selected conditions by selected peer group countries, age standardised DALY. This is the Disability Adjusted Life Year Rates 2013. So this blue bit here this is New Zealand. So these top bars here are New Zealand. And here's Australia, Canada, Ireland, UK and US, so you know, comparable countries. And as you can see, this is coronary heart disease. Look, it's really big across all these countries. But here, look at depression. It's really big. It's bigger than stroke. It's bigger than diabetes, COPD, bowel cancer, addiction disorders. Here's self-harm. It's quite big too. So in the scheme of things, it is a big contributor in the population. Okay, so what we're getting is these things are common. A lot of people are untreated. They cause a lot of disability in the population. They have a big impact. So can we improve matters by plugging the treatment gap? All right, now this is Australian data, but it has a New Zealand connection. This is a study by Gavin Andrews and company, who was at the University of New Zealand, but he was a New Zealander originally, so you can get credit for this. And this is a study he published on how much of the burden of mental disorders could be averted if we reduce the treatment gap. So this is all simulated data. So what he's doing is he's saying, let's look at treatments we have randomised control trial evidence for that work. And we can do a simulation about how much they can reduce the disability due to mental disorders. And we could say, let's imagine we could get more people into treatment. We can give them these evidence-based treatments. What could we do? So this is affective disorders, including depression as the major category. And this blue bar is how much of the burden in Australia we currently avert. This red bar is how much of the burden we could realistically, within feasible resources, avert. In this green bar is what we could do in a perfect system if we applied everything we knew. So we could substantially improve things. This is anxiety disorders. This is what we currently do. This is what we could do realistically. And this is what we could do in a perfect system. Anxiety disorders were very undertreated, so we could get enormous gains. Alcohol use disorders, very, very low burden averted currently. Realistic system, we could do much better. Perfect system, brilliantly. Here's schizophrenia, the current situation, realistic and perfect system. So schizophrenia, the gap is a lot smaller because we do a lot of treatment of schizophrenia because it's so severe, and things like anxiety disorders, alcohol use disorders don't get treated as much. So it looks brilliant. The treatment gap, this is the way ahead. The World Health Organization put out reducing the treatment gap as one of its goals for the world. Very important thing. Now, when all this came out, I totally believed it. I totally believe this is the way ahead, reducing the treatment gap. We've got all these evidence-based things. I believe they work. If we can apply what we know, we can produce major gains. However, it didn't work out that way. So I'll tell you about Australian data, but then I'll talk to you about the world and New Zealand as well. So in the Australian data, we've had big increases of treatment since the 1990s, but the prevalence rate hasn't gone down. So I won't give you all the details, but our per capita expenditure on mental health in real terms, adjusted for inflation, it's gone up enormously. Use of psychotropic medication of all sorts has gone up, particularly antidepressants. So when the SSRI antidepressants came in the early 1990s, it just went up and up and up, and it's continuing to go up, steadily increased. So in 2006, we got a major reform in Australia where people could get, our national health insurance system would cover treatment by psychologists, giving psychological services. And there was a massive uptake. So since 2006, there's massive uptake in psychological treatment. But over that time, the prevalence has been steady. So we haven't had the increase. So here's some data just to show you. Now this is a data looking at antidepressant use in a whole lot of OECD countries. This is Iceland, it's the biggest. So this light blue bar is Iceland in 2000, and this is Iceland in 2009. So you can see this is the increase that occurred just in those 9 years. This is Australia. It was the biggest after, that's what we had in 2000. This is what we had in 2009. 2000, I could tell you throughout the 90s it was increasing. This is over a very high base. Now look, this is the OECD average here. Now I look for New Zealand, it isn't there, but other data I've seen, I believe, there have been big increases in antidepressant and other psychotropic use. Okay, this is where I think Australia does have interesting data, because some people say, well, antidepressants, they're not great treatment, you really need psychological treatment. Well, I agree. So when we got this big reform in 2006, you can look at the number of these Medicares, our National Health Insurance System, mental health services per 1,000 people from 2006 to 2017. So Medicare used to just cover medical services. So here we have yellow bar, this is psychiatrists. So psychiatrists are always covered, and you can see there was a slight increase in psychiatric services, private psychiatric services. GPs were always covered, but they didn't get special mental health item numbers. So now they got funded to do longer consultations where they could do a mental health care plan, they could refer to a psychologist. And these ones increased dramatically. And then we've got psychologists and clinical psychologists. Clinical psychologists have higher qualifications. They increased dramatically. And then we have allied health. We had social workers and OTs, and they had a substantial increase as well. And the interesting thing about this is it's over such a short time. It was a very rapid increase. It blew the government's budget enormously, and you think, okay, such a wham of an increase, we should be able to see something. Okay, then when you look at the data on it, you can't really see very much. So we've had national health surveys in Australia for the last 20 years, which use something called the K10, stands for Kessler 10. It's a measure of psychological distress. So it covers anxiety and depression symptoms in the past month. And you get a score along a continuum, and you can put a cutoff on that score. So people who get very high scores, you can look how many people got high scores. So this blue bar shows very high scores. So these are people who really would be quite disabled by their symptoms, and this is an official health indicator in Australia, these very high. Then the orange bar is high plus very high, so it's a slightly lower cutoff. So if you take the really severe people, this is where we had 2 data points before the introduction of these extra psychological therapies. This is where they got introduced. We have all these data afterwards, and it's flat. If you look at the slightly milder people, yeah, it went down a bit, and people thought, yeah, it looks good, but then it went up. There's nothing there at all. Big surprise for all those resources. Now, I wondered when I saw these data in Australia, I thought, well, is this similar in other countries? And it's very difficult to get into another country's data. People that live there and work there, they know their own data better. So I emailed some colleagues in other countries. I emailed someone in Canada, someone in the UK, and someone in the US. And I said, look, I've done this analysis in Australia. Is it the same in your country? Can you do a similar analysis? So over the 4 countries, we did a similar thing. We found each of those countries, it increased dramatically, particularly in most of them, it's really medication use. Australia was the strongest for psychological therapy. And all of them, it's either flat prevalence or, if anything, maybe slightly getting worse, but none of them is getting better. So what about New Zealand? Well, Roger Mulder, University of Otago, give them credit, and some colleagues there. They did a debate piece in the Australian and New Zealand Journal of Psychiatry. I'm an associate editor, so I'm plugging the journal, the ANZJP, plugging the journal. So they did one, read this, very interesting, only a couple of pages. Why has increased provision of psychiatric treatment not reduced the prevalence of mental disorder? So they looked at the New Zealand data, and I'm not going to present it. You can read it, but it's the same thing. It doesn't seem to be any improvement despite increases in services. So why hasn't it worked? Now, I said at the beginning, I believed it would work. I totally believed in the simulation that Gavin Andrews did that this is the way forward. So it was a surprise to me that it hasn't. So why hasn't it worked? So I'm going to talk about 3 explanations. I'll tell you what they are, and then I'll go through each one at a time. First possibility is that it really did work, but the effect has been masked. The second one is what I call the quality gap, and the third one is what I call the prevention gap. So the first possibility, it has worked, but the effect is masked. So it could be that other things have been going on in society. So we were getting more and more treatments, but other things are going on in the background, and maybe some risk factors for mental disorders have been increasing at the same time treatment has been increasing, and so they cancel each other out. So when we did the international comparison with the people from Canada, US and UK, we looked at, is it possible in our societies that something like that could be going on? And we looked for things like, terrorist attacks and natural disasters and so on, and spikes of economic recession, and we couldn't see anything there that could easily account for it. However, there are a zillion changes going on in society over time, and whenever I talk about this, people say, what about people having more junk food? And we heard it today, more mobile phones, okay? All these things going on, and people say, well, maybe it was that, and there are many, many possibilities, but I have not been convinced yet that there's some change that you could see that could account for it. One of the reasons I'm not convinced is that in Australia, the change in provision of psychological services was very rapid. So with antidepressants, it was over 2 decades, and it was very slow. So you say, oh, something could be going on there. But with psychological therapy, it was a big hit. So you think we should be able to see that because there's not much room for background factors to go on. So I'm not convinced of that, but it is a possibility. The other one that I think was a real possibility is that people have become more willing to report symptoms. So we didn't have good data on this in the past, but I'm old, so I do remember what it was like. And the taboo about talking about your mental health, I can say from personal experience, was much stronger than it is now. Like in Australia, we get politicians who say, I had an episode of depression, I'm taking time off, I'm coming back, and people think, great, good, that's fine, no problem. That could never have occurred in the past. It would have been political suicide for somebody to say that they had a history of depression or anything else. So it may be that it's become more acceptable to talk about it. So in these national surveys, some lay interviewer comes into your house and asks you all these questions. I've never met this person. Am I going to tell them about all these personal feelings? Or if they give me, they phone me up by phone and they ask me the K10 questions, am I really going to tell this stranger over the phone about it? So if people are more willing to talk about these things, maybe that's a factor. Now, this one did concern me. This could be true, and I thought about this for years. How could we possibly test that? Because there is no way around it. These things are necessarily subjective. It's like pain. There's no objective test. It's what you experience is the reality. And it could be that if I'm willing to express it to others, it could increase, and we may not be seeing the treatment effects. So anyway, then I realised, it took me a few years, but I realised I had the data to test it. And the data I had is that I've been involved, my wife and I started this training program called Mental Health First Aid years ago, which has become very common around the world now. And we've done a whole lot of trials on mental health first aid. And so what we do is we randomise people to get mental first aid training, or they get some control group like physical first aid. And one of the things we do is we evaluate stigma. And we ask people a question about, if you had a certain type of mental health problem, would you be willing to talk to people about it? And after people get trained in mental first aid, we find a reliable effect. They're more likely to say, I would talk to people about it. So they're more open about it. We also had measures of their mental health from the K10 questionnaire in there. So we thought, okay, if this training makes people more willing to talk openly, then it should drive their symptom score up over a very short period of time. So anyway, we've done this complex analysis. This is a simplified version of it all. I brought up a menu that's not supposed to be there. I hope it'll disappear. Okay, so we do this, and it could be the training has a direct effect on symptoms, but it could be that it's making people more willing to talk about it, and then they report more symptoms. So we've done this analysis now with adults and with adolescents, and we can find no evidence. So that makes me think that being more willing to talk about it isn't really the explanation. I've done the wrong thing with this menu here. Let's see if I've buggered it. Okay, I hope this will work now. Okay, all right. So they're the artifactual ones. Okay, it is possible there's been some gradual change to society. I don't think it's a reporting matter. So the next possibility is the quality gap. I made up this buzzword just to contrast with the treatment gap. You know, it's just a summary thing, the quality gap. So the treatments that people used in these simulations like Gavin Andrews did are all about randomised controlled trials. Now, randomised controls are wonderful things, wonderful scientific things, but you're looking at things under idealised conditions. So you're looking at, you know, highly manualised therapy where people are doing it in a very standardised way, people are checking they're doing it thoroughly, they're getting people to come back and do as many sessions as needed and so on. It's not necessarily typical conditions, and it may be that in practice people don't apply it in the same way, or they don't apply it to the same group. And I think there's evidence for that. So for example, when you look at antidepressants, the evidence seems to be that if you're really severely depressed, that's a thing that on average is helpful. But for people with very mild depressive symptoms, probably isn't. But when you look in Australia, for example, most antidepressants aren't prescribed by psychiatrists, they're prescribed by GPs. And the GPs are giving them for chronic low-level depressive symptoms, which they're probably not very useful for. The other thing you see is that when you look at the epidemiology of depression, say, and I think it's true in Australia, and I think it's true in New Zealand too, it's sort of like young adults to middle-aged adults, you show this peak, and then when you get to old age, it actually gets better. It's great being old, I can tell you, apart from the physical, it's great for mental health. But when you look at the antidepressant use, it just goes up with age. So it's not tracking as it should. You think where the peak prevalence of depression should be, that should be the peak use. So it seems that people are accumulating these antidepressants prescribed by GPs and they're sticking on them throughout their lifespan. So they're not being targeted at the right people, perhaps. The other thing is that with psychological services, they often seem to be of poor quality. So when you look at clinical practice guidelines to say, this is under ideal circumstances, this is what you should do, you've got to have a hell of a lot of sessions. Like to treat depression or anxiety disorders, it's a lot of sessions. When you look at what people get, it's often 1, 2, 3, 4 sessions. It's nowhere near the minimum quality you would expect that people evaluated in trial. So that could be a reason that things haven't been working. So here's another advertisement for the Australian and New Zealand Journal of Psychiatry. It's a great journal. I wrote a thing called The Quality Gap in Mental Health Treatment in Australia. You can read about that. And I reckon probably the same thing applies in New Zealand as well. So the next explanation is what I call the prevention gap. So to understand this one, you've got to know some basic epidemiology. You've got to know the difference between incidence and prevalence. And a lot of people don't. And when you do, it's important you know, because then you can call yourself an epidemiologist. This is really all they know that other people don't. It's the difference between prevalence and incidence. So what happens is that when you go out to these surveys and you ask people about their symptoms in the last month or the last 12 months, you're looking at prevalence. You're looking at the number of people out there at a certain time that have these symptoms and these mental disorders. And that's different from incidence. Incidence is how many new cases are arising over a period of time. So I'll illustrate it with this tank. So here's a tank, and each little ball in the tank represents somebody who's got an illness, okay? And the prevalence is the number of people who are in the tank at any one time from the population. And we're getting people who are coming into the tank, flowing in, and this is the incidence, it's actually a rate. How many coming in per year, per month, that's the incidence, the rate of inflow. The prevalence is how many are in there or are affected at any one time. And then you get people who recover or they can die and they come out here. Now, when you look at treatment, what treatment does, it's all about the outflow. It's all about trying to get people, once you get the problem, getting you better and getting them out quickly. It has nothing to do with the inflow. So you can reduce the prevalence two ways. You can get people out quickly or you can stop them getting in. So services are primarily aimed at duration. That is, how long you're in the tank. And what we might need to do is put more emphasis on decreasing the inflow, the incidence. And here's another advertisement for the good old ANZJP. So I've done an article in there, which you're most welcome to read, called Why Hasn't the Mental Health of Australians Improved the Need for a National Prevention Strategy? Because I think this is perhaps what we need, a national strategy for how we could go about preventing mental disorders. Now, some people are sceptical about prevention. Is it possible? And there are enough randomised controlled trials now to say that I think, yes, in principle, it is possible. In Australia, a few years ago, we got a National Mental Health Commission to advise the government on these issues, and they recently funded some health economists at Deakin University to do a return on investment analysis of prevention. So what these economists were asked to do was to look at various preventive interventions that had a randomised controlled trial, and then to look at the cost of those interventions, and then look at how much money was saved. For health economists, it's a pretty simple sort of analysis. They don't like it that much, but it's really good for politicians because it's lay people like me. It's really simple to understand. So what you do is this. You get an intervention like e-health interventions for the prevention of anxiety disorders in young people. The target population is school students aged 11 to 17. You can look at the benefits over 10 years. You can look at the total cost of the intervention. You can look at the total savings. And then you get this thing, which is the return on investment, the ROI. So it says 3.06. So what it's saying, for every dollar you put in, there's $3 of benefit. So good. Here's another one. This one gives $2.87, I think. So this is educational interventions to reduce older persons' loneliness. The target is women aged 55 years and above residing in the community. The length of the evaluation is 5 years. It costs $25 million and you get 72 back. Here's one that has a return on investment of about $2.50. Exercise programs for prevention of postnatal depression aimed at women at least 4 weeks post-birth for 5 years. Here's one about $2.40. Parenting interventions for the prevention of anxiety disorders in children aimed at preschool children. $2.14, I think it says. E-health interventions to reduce older persons' loneliness. Target is lonely older persons aged 65 and above enrolled in a community visitor scheme. Here's psychological interventions for the prevention of postnatal depression aimed at pregnant women, $1.63. School-based interventions to prevent bullying, $1.56 per dollar invested. School-based psychological interventions to prevent depression in young people, $1.19, probably not worth it. E-health workplace intervention for prevention of depression, $1.05, probably not worth it. And here's face-to-face psychological workplace intervention of depression prevention, definitely not worth it, definitely worth it. So there are things that in these sort of modelling could work. The problem with modelling is like Gavin Andrews' modelling. It's these are what the trials show. And if you follow through the logic, yeah, it seems to work. But it is quite possible with all of these you're going to get a quality gap. The way it's implemented in practice may not produce these benefits. We just don't know that. We don't know. It may be possible to do these in a more standardised way than it is with treatments, so maybe you can help reduce the quality gap that way. The other thing to say about these preventive interventions is that basically they're like psychological type interventions that have been used for preventive purposes. So these are sort of interventions in many cases you could use for people that are at the disorder level, they're way up that end, and they've been brought down for people who have mild symptoms that are just below disorder level, or people who have no symptoms for preventive purposes. So they're basically psychological therapies that are sort of moved down the continuum. And they're good because you can do randomised controlled trials and you get nice evidence, but I don't think they're really where the big action is. So when you look at the big action in chronic physical diseases, you look at why have we got big gains in heart disease and cancer? It's about risk factor modification. So we try and reduce smoking, and I heard the data in New Zealand, same as Australia, many countries, it's gone down dramatically. It's taken 50 years to get it down dramatically, but it's gone down. We look at ultraviolet exposure, that's a big thing in Australia. Skin cancer, yeah, people wear hats, baldies like me have hats all the time now, put on sunscreen every morning, that sort of thing. We look at sodium in the diet, a lot less salt in the diet than there used to be. So these are the big risk factor modifications that make a difference. Very hard to do randomised controlled trials on them. So when you look at mental disorders and you say, well, what are our big risk factors? They are various really bad things that happen in childhood. People call them adverse childhood experiences. So here's the Australian New Zealand Journal of Psychiatry again. And here's the New Zealand connection. I did this with Roger Mulder from the University of Otago. We did this together, this viewpoint on it. On prevention of mental disorders requires action on adverse childhood experiences. So the sort of experiences we're talking about are things like physical abuse, sexual abuse, emotional abuse, neglect, living with a parent who shows substance abuse, who shows criminal behaviour, has a major mental illness, things like bullying, living in child poverty, they're the sort of major experiences that are important. Now, the interesting thing about these is they cluster. So people who have one of these in their lives tend to have more than one. They go together. So you don't get them singly. They seem to cluster together in families. A second thing that's really interesting about them is that they're very non-specific in their effects. So when you look at risk factors for different types of mental disorders, often you can get different types of risk factors, but these are across just about probably all mental disorders. I can't say all, but everyone I've looked at, you find, you can look at eating disorders, you can look at psychotic disorders like schizophrenia, you look at anxiety, you look at depressive disorders, and these are there. These ones are there. So they have broad impact across a whole range of mental disorders. And they're also important for physical health, because you can look at a whole lot of physical health problems and you find these are related to them as well. So you can get a big bang for your buck if you could reduce these. And the other thing is they have a lifespan impact. So, you think of children and things happen to children, and that's bad for the children's mental health. But you can look at studies that are done with old people who have mental disorders, and you look at their exposures, and they have these things way back, half a century before in their lives, and they're still there. So we're getting clustering of these in certain families. We're getting across a whole range of mental disorders and many physical disorders as well, and we're getting a lifespan impact. So the potential would be enormous if we could do something about it. And we don't know a lot about that, but I think this is really what we've got to work at. The other thing is there are other determinants that are, many of them outside the health sector and some in the health sector, but outside the mental health sector. So when you look at surveys that have been done using this Kessler 10 questionnaire, and I've been through all the ones that we've done in Australia, and I've no doubt it'll be similar in New Zealand, and you look at who has high psychological distress. This is anxiety and depressive symptoms. It's the unemployed, people with low income, people with low social connectedness and low social support. There are various workplace characteristics that are associated with K10, poor quality diet, and there are some physical ones too, limitations on physical functioning and various physical diseases. So there are broader things that are beyond the health sector, and some things are in the health sector but beyond the mental health sector. So if we really wanted to do something about improving mental health, it really is like a whole of society, whole of government thing. It really The determinants are beyond the limitations of the mental health sector. So, in summary, in case your attention lapped, here we go again. Closing the treatment gap has not improved population mental health. Possible reasons for this include there's a quality gap in services and there's a prevention gap. And I think this is a major challenge for the mental sector that we can't ignore. I would like to get up and say all these increases in services are wonderful and have done a great thing, and I do totally believe in mental health services. I think they have a very important role to play, but I don't think we could ignore that we owe it to the people who are affected by mental health problems to do a better job in all of this. One other lesson out of all of this is that, and this is from an Australian perspective, what we get is ministers for health who love promising things in election and rolling out reforms, and they get rolled out nationally, and a few years later somebody does an evaluation of it all and it doesn't really look quite as good as we thought it would be, and it's very hard to go backwards. And really what I would really like to see more is a more experimental society where we actually test things out under real life conditions on a small scale, and then if it works, roll it out. And if it doesn't work, let's try something a bit different and tweaking it before doing it, because it gets so hard to go backwards. We're seeing this now in Australia. We're getting national suicide trials where we're getting regions of the country that are being randomised to get enhanced services to prevent suicide, and others are control regions, and I think that's a great approach. I've also seen it in Finland, where they're doing a national randomised trial on universal basic income. So people that are unemployed, they randomly assign them, the government, to either get universal basic income or standard services. The evaluation is still ongoing, but when you look at the data they have, it seems to increase well-being. And I think this is what we need, a more research-oriented, experimentally oriented society. So that brings me to the end. Thank you. That's it.